Look at the dent above this child's right temple. Number 10. The child who survived the blow. Around 100,000 years ago, inside Qafzeh Cave in what is now Israel, someone laid a child into the earth and placed deer antlers across the small body. But the burial was not the first mystery. The skull carried a deep, depressed fracture, and the bone had already begun to heal. Whatever happened, the child lived long enough for the body to try to repair itself. The question is not only what struck the skull, it is what happened afterward, and who helped this child survive it. The child was about 12 or 13 when death finally came. The sex remains unknown, and any name was lost long before history began recording them. Near the entrance of the cave, the body had been laid on its back. The head rested to one side. Both arms were bent, with the hands drawn close to the face. At some later point, a falling stone crushed much of the lower skeleton. Even so, the original arrangement remained surprisingly clear. Scavengers hadn't pulled the bones apart. The grave hadn't collapsed into complete disorder, and the antlers were still there. They rested across the child's chest and near the palms, in positions that are difficult to explain as chance. Someone appears to have placed them there when the body entered the ground. Then researchers looked more closely at the wound. From the outside, it could once have been described as a relatively limited injury, a damaged patch of frontal bone above the right temple. Three-dimensional reconstruction made that interpretation impossible to maintain. The bone hadn't simply split. A roughly four-sided fragment had been forced inward. Fracture lines spread outward from the point of impact, like the arms of a star, while part of the broken section pressed into the space once occupied by the brain. Something had struck the child with considerable force. The shape is consistent with blunt trauma. A fall could produce it. So could a kick or a blow from a heavy object. The skull can't identify the exact cause, and it certainly can't tell us whether another person was standing nearby. Archaeology rarely gives investigators that kind of clean confession. What the skull can do is separate an injury suffered during life from damage caused after burial. Living bone responds. It tries to rebuild itself. Along one edge of the fracture, a thin layer of new tissue had begun to form. The repair was incomplete, but it was real. The child hadn't simply been struck at the moment of death and placed in the grave. Some amount of life followed the injury. The reconstruction allowed researchers to trace the damage inward. By rebuilding the internal surface of the skull, they could estimate where the displaced bone had pushed against the brain. The affected area lay close to regions associated with planning movement, directing visual attention, dealing with unfamiliar tasks, and taking part in social communication. None of that lets us reconstruct the child's personality or behavior. A fossilized skull can't preserve confusion, difficulty speaking, or a change in judgment. Still, the location makes lasting problems plausible. Another measurement added to the concern. The teeth placed the child at roughly 12 or 13 years old, yet the space inside the skull was smaller than expected for that age. Its proportions were closer to those of a much younger child. Researchers proposed that the trauma may have interfered with later growth of the cranium and brain. They couldn't match the injury to a precise list of symptoms, and they didn't claim to. What they could show was that the earlier idea of a minor, harmless blow no longer fitted the physical evidence. That difference matters. A healing fracture proves that the child survived. It doesn't automatically prove constant care, affection, or compassion. The injury may have left fewer problems than its appearance suggests. Help may have been occasional. The child may still have managed many ordinary tasks alone. The motives of the group are beyond recovery. But a serious brain injury in childhood doesn't end when the bleeding stops. It can disturb balance, attention, movement, judgment, and communication. Those are not abstract medical categories when life involves open fire, sharp stone tools, steep ground, and a group that may need to move with the seasons. Even a limited impairment could make an ordinary day more dangerous. Perhaps someone slowed down when the child fell behind. Perhaps someone watched near the fire or repeated a task that no longer came easily. Food may have been shared. During movement, the child may have been kept close. The grave can't prove those individual actions. It offers another kind of evidence. When the child died, the body wasn't abandoned on the cave floor. It was lowered into a prepared pit. The hands were placed near the face. 2 red deer antlers were arranged against the upper body in a way not repeated quite the same way in the other Qafzeh burials. The fracture records what happened to the child. The thin layer of healing bone records that life continued afterward. And the antlers show that, when that life ended, someone came back to the body and decided how it would be left. Care doesn't produce a fossil of its own. Sometimes the only trace lies in the distance between a wound and a grave. The next individual carried no dramatic fracture. His problem emerged slowly, one missing tooth after another, until almost nothing remained with which to eat. Number 9. The skull with one tooth. Beneath the ruins of a medieval town at Dmanisi in Georgia, excavators reached a layer almost 1.8 million years old. In 2002, they uncovered a nearly complete skull. The following season brought the matching lower jaw. Nearly every tooth had disappeared. Only one lower canine remained. At first glance, the empty spaces might look like damage caused during excavation or burial. Teeth often loosen and fall away after death. That wasn't what had happened here. The sockets had already begun to close. After a tooth is lost during life, the jaw no longer needs to maintain the bone that held it in place. The socket gradually shrinks. Its edges soften, and the surrounding bone withdraws. It is a slow biological response, and in this individual, it had happened across almost the entire mouth. Most of the teeth had been gone for years before death. An empty jaw had become a record of survival. Molars do a great deal of work. Their broad surfaces crush tough plants, break down resistant foods, and reduce meat into pieces that can be swallowed safely. A jaw can still open and close without them, but the movement has little useful surface to work against. The one surviving canine offered almost no grinding ability. Hard food would have been extremely difficult. Tough pieces could become a choking risk. Even if the same meal was available to everyone in the group, this individual may have needed it softened, broken apart, or selected differently before eating. So how did someone with only one tooth continue living in the Caucasus nearly 1.8 million years ago? The most immediate answer was that other group members helped. They may have selected tender food, shared marrow, or cut meat and plants into pieces that could be swallowed. Someone might even have chewed food before passing it over. If any of those things happened regularly, Dmanisi would preserve an extraordinarily early case of one member, Homo supporting another, whose body could no longer meet a basic need. But the evidence doesn't take us quite that far on its own. The site contains simple stone tools and animal remains. A sharp stone edge could slice meat into smaller portions, reducing the amount of chewing required. Marrow, brains, and other soft tissues could be eaten with very little grinding. Ripe fruit, tender plants, or naturally soft foods may also have helped. The individual may have mashed food with tools, worked it between the tongue and gums, or developed methods that left no visible mark on the skeleton. That uncertainty isn't a weakness in the case. It is the case. The jaw confirms extreme tooth loss. The remodeled sockets confirm that the individual survived for a long time afterward. Between those two facts lies a range of possible lives. Perhaps food was handed over at every meal. Perhaps help was needed only for certain foods. Perhaps the individual could still gather, choose, and prepare enough independently. The most likely explanation may involve all three elements: personal adaptation, tool use, and continued access to resources within a group. The strongest conclusion is less dramatic than compassion proved, but it is still important. Losing almost every tooth didn't immediately remove this individual from social life. Even the familiar description of an elderly man is less secure than it sounds. The skull has often been identified that way, while some anatomical interpretations have suggested that. The relatively gracile individual may have been female, and elderly means something different when discussing a human relative who lived nearly 2 million years ago. The skeleton gives us severe tooth loss and survival. It doesn't provide a birthday, a name, or a clear social role. What it does preserve is time. A tooth can disappear in a moment. A socket takes far longer to close. As the upper and lower jaws resorbed, the shape of the face gradually changed. A mouth that once contained a working set of teeth became shallow and nearly empty. Throughout that process, the body still needed calories. This wasn't like a single accident followed by recovery. There was no one afternoon when help arrived and the crisis passed. The difficulty returned with breakfast, with the next meal, and with every tough piece of food placed in the mouth. Someone may have cut portions smaller. Someone may have surrendered the softer pieces. Or the individual may have found solutions that archaeology has no way to see. The bones can't assign credit. They show only that the teeth vanished, the jaw adjusted, and the person went on living. The most revealing part of the skull, then, isn't the final canine. It is the empty bone surrounding it. Those closed sockets preserve the slow loss of one of the body's most basic abilities, and the fact that losing it wasn't the end of this life. At Qafzeh, healing followed a violent blow. At Dmanisi, survival continued through years of gradual loss. The next skull records something more deliberate. 2 openings made by human hands, both of them followed by healing. Number 8. The 2 holes that healed. In 1992, archaeologists entered a burial chamber cut directly into volcanic rock at Pontecagnano in southern Italy. A young man lay at its center, curled onto his right side. A clay vessel and a stone knife had been placed nearby. Nothing in the grave immediately announced the man had survived an operation on his skull. The first opening lay near the top of the head, close to the point where the frontal and parietal bones meet. It was broad, shallow, and roughly crater-shaped, extending almost 5 centimeters. A second opening appeared farther back. This one was smaller, deeper, and more conical. Holes in ancient skulls can be deceptive. Disease can eat through bone. Roots can enter cracks and enlarge them. Water, pressure, and movement in the soil can alter a skeleton over thousands of years. A weapon can also puncture the skull during life or around the time of death. Before calling this surgery, researchers had to show that both openings had been made deliberately and that the man had survived them. The edges provided the first answer. Newly broken bone is sharp. The margins around these openings were rounded, thickened, and smooth. New tissue had grown across the damaged surfaces, gradually blending them back into the surrounding skull. The healing was especially clear around the larger opening. Whatever had made these holes, the man lived for months afterward, and perhaps for years. X-rays and 3-dimensional CT scans then revealed details hidden beneath the outer surface. The walls of the larger opening sloped inward, but not evenly. One area had been thinned more than another. The marks followed a clockwise sequence, consistent with a right-handed person facing the patient, and repeatedly scraping the bone with a sharp stone tool. This wasn't one quick strike. The tool had moved around the same area again and again, shaving the skull thinner until only a small opening remained at the center. The second hole preserved a different technique. It was narrower and cone-shaped. Instead of removing the bone in widening circles, someone had worked at the outer surface with a pointed tool. The operation stopped before the inner layer of the skull was completely penetrated. 2 openings had been made in 2 different ways. Both had healed. That might have settled the investigation, until researchers examined the rest of the skeleton. The right thigh bone was badly damaged. A powerful force had broken the shaft across the middle, and the 2 sections had never reunited properly. New bone formed around the injury, but the original break remained visible. A channel also ran through the thickened shaft, allowing infected material to drain. The disease had spread deeply through the bone and may have reached the opposite leg through the bloodstream. This was chronic osteomyelitis, a persistent infection that can produce swelling, fever, weakness, and severe pain. The fracture wasn't simply an old injury that had healed badly. It remained an active source of illness. Walking would have been difficult. During a flare-up, it may have been impossible. Now the holes in the skull had to be reconsidered. They may not have been created in response to head trauma at all. Researchers proposed that the larger trephination could have been an attempt to relieve suffering associated with the infection in the legs. The smaller opening may have served a different purpose, possibly symbolic, therapeutic, or some combination that no longer fits neatly into modern categories. The skull can't preserve the diagnosis spoken before the procedure. It can't tell us what the operator believed would happen. It does preserve the physical sequence. Someone had to steady the patient while a stone tool worked against living bone. The pressure had to be controlled closely enough to avoid, plunging through the skull and into the tissues beneath. The scraping continued until a broad depression had been created, then stopped while the man was still alive. Afterward, The wound stayed clean enough for substantial bone repair to begin. That recovery required more than a skilled hand during the operation. The patient was living with an unstable, infected thigh. He may have needed help standing, walking, or cleaning a wound that continued to drain. During recovery from the cranial procedure, he also needed shelter, food, and protection from further injury. The exact purpose of the operation remains uncertain. The physical evidence is firmer. The openings were deliberate. Different tools or techniques were used. Both procedures were followed by survival. This wasn't a hole made experimentally in the skull of a dying man. Look closely at the larger opening, and the movement is still there. Its angled walls follow the turn of the tool. The healed margins preserve the months or years after that movement stopped. Nearly 5,000 years later, one skull still carries both sides of the procedure, the operation and the recovery. The child in the next case underwent no surgery. One part of the skull simply closed before it should have, forcing the rest of the head to grow around the mistake. Number 7. The skull that closed too early. Deep within the Atapuerca cave system of northern Spain, a vertical shaft descends into a chamber called Sima de los Huesos, the pit of bones. Thousands of human fossils have emerged from that chamber. Among them were dozens of fragile cranial pieces that, viewed separately, didn't seem especially remarkable. Once the fragments were joined, the shape became impossible to miss. The skull belonged to a child. Seen from the front, one side sat lower than the other. Viewed from above, the rear of the cranium twisted away from the center. The left side bulged outward, while structures at the base of the skull had shifted from their normal positions. This wasn't pressure from sediment, and the distortion hadn't appeared after burial. The skull had grown that way. The cause lay along the lambdoid suture, one of the flexible seams connecting the bones at the back of a child's head. During normal development, these sutures remain open while the brain expands. New bone forms along their edges, allowing the skull to enlarge without trapping the brain inside a rigid case. In cranium 14, part of the left lambdoid suture had fused too soon. Once that seam closed, growth could no longer continue evenly across it. The rest of the skull compensated by expanding in other directions. The result was a twisted vault, displaced structures near the base, and a clear imbalance between the two sides. Researchers diagnosed the condition as single suture lambdoid craniosynostosis. The severity of the distortion added another clue. It appeared on both the outer and inner surfaces of the skull, suggesting that the fusion had begun before birth. This wasn't a condition that appeared shortly before death. It had shaped the child's head from the beginning. A virtual reconstruction of the inner surface showed how the brain case adapted. One temporal region sat farther forward than the other. The occipital area projected unevenly. The brain itself was gone, but the surface that once enclosed it preserved the shape under which it had developed. Craniosynostosis can affect vision, coordination, and development, especially when the distortion is severe. But the effects vary from one person to another. That uncertainty has to remain part of the story. Cranium 14 establishes the disease. It doesn't preserve intelligence, personality, or a precise level of disability. An unusual-looking skull is not evidence that the child was completely helpless. What the bone does establish is duration. Dental development and the condition of the skull indicate that the child reached late childhood. The fused suture had therefore shaped life for years. It hadn't caused death in infancy when the abnormal growth first began. Season after season, the child continued eating, moving, and remaining within the group. Did that require assistance? Possibly. Distortion of this degree may have affected sight, balance, coordination, or movement. But the most defensible conclusion is more restrained. The group didn't abandon this child simply because the skull developed differently. Life in the Middle Pleistocene allowed little separation between disability and the ordinary. Demands of survival. Food had to be obtained. Exposure had to be managed. Injuries had to be endured. Groups moved through uneven and sometimes dangerous terrain without surgery, stored medicine, or specialized shelter. A child didn't need to be totally dependent for additional attention to matter. Someone might need to slow down. Food might need to be shared. The child might require protection near steep ground, or acceptance when. Certain tasks couldn't be performed as easily as they were by others. Researchers have therefore argued that cranium 14 belongs in. Discussions of social behavior among these ancient humans. That doesn't turn the fossil into direct proof of compassion. It does mean the child can't be treated as a medical. Curiosity, detached from the group in which survival occurred. The simpler story would end with a diagnosis, an early example of a rare developmental condition. The fuller story is written in time. The skull began growing differently before the child had any control over it. Growth continued for years. As the rest of the cranium expanded around the fused seam, every layer of new bone recorded another period of survival. Unlike the young man at Pontecagnano, this child carried no mark left by a surgeon. No tool entered the skull, and no operation attempted to reopen the closed suture. Here the evidence lies in the opposite process. One narrow line of bone sealed itself too early. The whole head changed around it. Life continued inside. The fused seam is small enough to hide beneath a fingertip, yet it preserves the difference between being born with the disorder, surviving long enough for that disorder to reshape the entire skull. The next child left an even smaller clue. The story isn't written across the whole head. It is hidden inside the chambers of one ancient ear. Number 6. The inner ear that changed the child's story. In 1989, excavators at Cova Negra, a cave near Xàtiva in eastern Spain, recovered a small fragment from the right side of a skull. It belonged to the temporal bone, the dense structure surrounding the organs of hearing and balance. From the outside, it appeared to be little more than a broken piece of bone. The evidence was buried inside it. Decades after the excavation, researchers examined the fragment using micro-computed tomography. The scanner sent X-rays through the fossil from hundreds of angles, then assembled the resulting slices into a three-dimensional model. Without cutting into the specimen, the team could enter the tiny spaces enclosed within it. The scan reconstructed the cochlea, the vestibule, and the three semicircular canals. The cochlea is the coiled chamber involved in hearing. The canals are three small loops filled with fluid, helping the brain detect how the head is turning and where the body is positioned in space. One of those loops immediately looked wrong. The lateral semicircular canal was unusually large and misshapen. The anterior canal hadn't developed normally. The vestibule was smaller than expected, and the cochlea also had reduced volume. The channel that carries fluid away from the inner ear was enlarged. A small fistula even connected structures that should have remained separate. These weren't cracks produced by pressure or decay. The abnormalities had formed while the child was developing. Before diagnosing the condition, researchers first had to establish whose bone they were examining. They compared the proportions of the reconstructed inner ear labyrinth with Neanderthals, fossil Homo sapiens, and living humans. The fragment matched the Neanderthal pattern. Other structures inside the temporal bone helped estimate age. Researchers examined the development of the petromastoid canal and the nearly closed subarcuate fossa. Their conditions showed that the individual had lived beyond 6 years. That estimate mattered. This wasn't an infant who died before the abnormalities could shape daily life. The child had lived with them through years of movement, learning, and growing independence. The next question was harder. What condition could produce this exact combination of defects? A single malformed canal wouldn't be enough for a diagnosis. Several developmental syndromes can affect the inner ear. The researchers compared the complete pattern with Charge syndrome, Waardenburg syndrome, Pendred syndrome, and other possibilities. Some could explain one abnormality, but not the rest. The presence of all three semicircular canals weakened the case for Charge. A normal posterior canal argued against another diagnosis. When the researchers placed the reduced vestibule, small cochlea, and malformed lateral canal together, the closest match was Down syndrome. The conclusion is anatomical, not genetic. No chromosome was visible in the scan, and ancient DNA didn't confirm trisomy 21. The careful statement is that the complete inner ear pattern was most compatible with Down syndrome. Even without assigning a name to the syndrome, the bone recorded significant functional problems. The reduced cochlea would have caused severe hearing loss. The malformed balance organs were associated with vertigo, poor equilibrium, and difficulty sensing the position of the head. Infection may have intensified those symptoms. For a child learning to cross rocky ground, keep up with a moving group, and respond to warnings, the consequences would have been practical, and immediate. Sound may have arrived faintly or not at all. Without warning, the world could seem to tilt. And yet, the child lived beyond 6 years of age, well past the period of complete dependence in infancy. That survival forms the second half of the case. Cova Negra wasn't a permanent village with fixed houses and stored food. Neanderthal groups used the cave during shorter occupations. They moved through a landscape where food had to be found, transported, and shared. A child with severe problems of balance and hearing couldn't simply remain in the safety of a settled home, while everyone else traveled and worked nearby. The research team argued that a single parent would have struggled to meet those needs, while also obtaining food, moving through the landscape, and caring for herself. Surviving beyond 6 years therefore suggests help from other members of the group. Someone may have steadied the child while walking. Someone may have carried the child when vertigo made movement impossible. Others could have watched during dangerous moments or taken over tasks the primary caregiver couldn't manage alone. The fragment can't name those people. It can't tell us whether they acted from affection, obligation, or some social expectation that no longer has a name. Nor can it tell us exactly how much the child managed independently. What it does challenge is the idea that Neanderthal care existed only as an exchange between capable adults. Help now in return for help later. A young child with a serious developmental condition offered no guarantee of future repayment. The fossil is smaller than a human palm. Its outer surface carries no spectacular wound, no cut, and no obvious sign of disease. Inside it, however, one swollen canal, one reduced chamber, and one passage that grew too wide, preserved years of difficulty with sound and balance. A fragment that once looked almost anonymous had become the record of a childhood, and of the group within which that childhood continued. Number 5. The shoulder that had to be moved. In 2013, archaeologists working beneath the foundations of a later precinct at Pachacamac, on the central coast of Peru, uncovered 3 funerary bundles associated with the early Yishma period. One of them contained the remains of an elderly woman, catalogued as H3-CF3. Her grave lay close to the northern facade of the old temple, inside one of the most important sacred centers in the Andes. Yet the most revealing objects in her burial were not ornaments, offerings, or ceremonial goods. They were 2 extra bones growing from the base of her neck. Most people have 12 pairs of ribs beginning in the upper chest. This woman also had cervical ribs extending from the lowest vertebra of the neck, one on each side. Cervical ribs do not always cause problems. Some people live with them and never know they are there. In this case, however, the damage elsewhere in the skeleton suggested that the extra bones had affected the way she used her upper body for years. The space between the lower neck and the shoulder is already crowded. Major nerves pass through it on their way into the arm, along with the blood vessels that supply the limb. An extra rib can compress those structures. The result may be pain, numbness, weakness, swelling, or loss of control in the hand and arm, especially when the shoulder is raised or held in certain positions. Modern medicine calls this thoracic outlet syndrome. Her right shoulder appears to have absorbed the consequences. The head of the humerus, the rounded upper end of the arm bone that should move smoothly inside the shoulder socket, showed severe osteoarthritic destruction. This was more than the ordinary wear expected in an elderly skeleton. The joint had been repeatedly loaded in an abnormal way. Researchers propose that the woman may have been repositioning her shoulder again, and again to reduce pressure on the nerves or blood vessels trapped beneath the cervical rib. That adjustment may have relieved one kind of pain, while creating another. A slight change in posture, repeated for years, gradually damaged the joint. Reaching upward, lifting, carrying, or holding objects with both hands would have become increasingly difficult. Tasks that required strength or stability on the right side may have taken longer, required a different technique, or become impossible without help. The original condition began with 2 small bones in the neck. Its effects spread through the way she moved every day. The researchers did not infer care simply because she was old or physically impaired. They followed the mechanical chain preserved in the skeleton. The cervical ribs created compression. The compression encouraged compensatory movement. That movement damaged the shoulder. The damage then limited what the arm could do. From there, they could ask a more useful question. Which parts of daily life would have become difficult And how might other people have adjusted around those difficulties? Then, a second feature on the skeleton complicated the case. High on the skull was a trepanation, an opening deliberately made through the cranial bone. Its margins had healed. Whatever instrument created the opening had not killed her. New tissue had formed around the edges, showing that she survived long enough for the skull to begin repairing itself. Why the procedure was performed is impossible to determine with certainty. It may have been intended to relieve pain or treat an illness that people connected with her. Physical condition. It may have served a partly therapeutic, partly ritual function. The people who made the opening may not have separated medicine and ritual in the way modern researchers often do. The skeleton does not preserve their explanation. It preserves the result. Someone carried out an invasive procedure on the skull, and the patient lived afterward. Her age places all of these changes on a long timeline. The cervical ribs had been present from birth. The shoulder damage accumulated through years of compensation. The trepanation healed before death. These were not three unrelated abnormalities appearing at the end of life. Together, they describe a body that had been repeatedly adjusted around pain, limitation, and treatment. Researchers approach the case using the bioarchaeology of care framework. The method asks several questions that are easy to collapse into one emotional conclusion. What could this woman no longer do easily? Which activities would have created pain or risk? What kind of assistance, accommodation, or change in workload might have reduced those problems? And does the archaeological context support the idea that such adjustments were available? The answer was not that she must have required constant nursing. She may have remained capable, productive, and independent in many parts of life. A painful shoulder does not erase knowledge, skill, or social value. Care may have meant something much less dramatic than continuous physical support. Certain jobs could have been reassigned. Heavy loads might have been carried by someone else. She may have avoided movements that compressed the nerves beneath the extra rib. Another person might have helped with tasks requiring both arms, or simply allowed her more time to complete them differently. Dependence is rarely absolute. A person can need assistance in one part of life, while remaining fully capable in many others. The skeleton also cannot tell us why help was given. It may have come from affection. It may have been expected within the household. It may have been reciprocal, connected with her age, her knowledge, or her standing in the community. Several motives could have operated at once. What the bones do show is that an elderly woman with a progressively damaged shoulder lived long enough for compensation, destruction, intervention, and healing to accumulate. The extra ribs began the process. The worn humeral head preserved years of altered movement. The healed edge of the skull opening recorded survival after an invasive procedure. Placed together, those details turn one funerary bundle into more than a catalog of disease. They preserve a life that had to be reorganized around pain. The next individual needed something more demanding than a lighter task or a protected arm. For years, even the most basic movements of his body may have depended on another person. Number 4. 10 years without independent movement. About 4,000 years ago, a young man was lowered into a grave at Man Bac, near the Red River Delta in northern Vietnam. He was buried among other members of the community. There was no separate monument, no unusual structure, and nothing in the grave that immediately announced the extraordinary conditions under which he had lived. The skeleton did that. His arms and legs were unusually slender. The shafts of the long bones lacked the strong structure, normally produced by weight-bearing and repeated muscular use. Several joints had developed abnormally, and the spine carried changes consistent with a neurological condition that began while the body was still growing. This wasn't the wasting that can occur during the last weeks of illness. Bone changes slowly. Muscles pull against it. Body weight passes through it. Walking, lifting, and repeated movement shape its thickness and internal structure over years. When those forces disappear, the skeleton gradually records the absence. In Burial 9, known to researchers as M9, that absence affected much of the body. The pattern suggested paralysis from at least the waist down, with severe restriction in the upper limbs as well. The precise cause remains uncertain. Researchers considered several possibilities, including a congenital condition, infection, and spinal injury. The surviving bones do not preserve enough evidence to identify one diagnosis with confidence. For understanding how he lived, The name of the disease matters less than the loss of function. M9 appears to have developed the condition during adolescence. He then survived with it for approximately 10 years, dying in his 20s. For most of that decade, he was probably unable to stand or walk independently. If the upper limbs were as limited as the skeletal changes indicate, he may also have been unable to feed himself, wash his body, or shift position without assistance. That last difficulty would have returned constantly. A person who cannot move his own weight develops pressure injuries where skin and tissue are trapped between bone and the ground. In a warm, humid environment, those wounds can become infected quickly. Immobility also raises the risk of chest infections, muscle contractures, and further weakening of the skeleton. Paralysis may disrupt bladder and bowel control, turning hygiene into an urgent medical problem rather than a matter of comfort. The people at Man Bac lived in a landscape of rivers, marshes, and limestone hills. Food still had to be caught or gathered. Water had to be carried. Meals had to be prepared. Shelter had to be maintained. There were no antibiotics, adjustable beds, or professional caregivers. Keeping M9 alive required far more than leaving food beside him occasionally. His body had to be repositioned. His skin needed to be kept clean and dry. Water and food had to be brought within reach or placed directly into his mouth. Waste had to be removed. During illness, someone needed to remain nearby. If the community moved, M9 either had to be carried or protected in place. No single feature on the skeleton proves every one of those actions. The argument comes from combining the functional consequences. Severe paralysis creates predictable needs. Survival for close to a decade means that enough of those needs were met, repeatedly, to prevent pressure wounds, dehydration, infection, or respiratory illness from ending his life much earlier. That is what separates M9 from a person who survives one injury and gradually returns to ordinary activity. There was no expected recovery waiting at the end. The assistance could not simply continue for a few days and stop. His condition returned every morning. The same tasks had to be performed again and again without knowing that the next week would be any easier. Cases such as M9 helped researchers develop the bioarchaeology of care. Rather than looking at an unusual skeleton and declaring that the group must have been compassionate, the method reconstructs the practical problem step by step. Which physical abilities had been lost? What complications would follow from those losses? Which forms of help could reduce those complications? Could the surrounding society realistically provide that help? For M9, the answers point towards support that was sustained, technically informed, and intensive. But dependence should not be confused with uselessness. A person unable to walk might still remember fishing grounds, teach younger members of the group, repair tools, watch children, advise others, or participate in decisions. Intellectual ability and social contribution do not disappear because the legs stop functioning. The skeleton cannot recover M9's knowledge anymore. Then it can identify the people who cared for him. Calling him only a burden would be another unsupported story imposed on the bones. The burial does establish one thing clearly: inclusion. M9 was placed in the same cemetery as other members of the community. He was not isolated after death as something dangerous, polluted, or outside the group. More importantly, the 10 years before that burial required other people to organize at least part of their daily lives around his continued survival. His thin limbs are easy to read only as evidence of what he had lost. They also record actions performed by people who may never be identified: lifting, cleaning, feeding, turning, carrying, and coming back the following day to do those things again. At Man Bac, care was not a single act of rescue. It was routine. The man in the next grave retained more ability to move, but his skeleton carried a different accumulation of losses. One damaged arm, impaired vision, an uneven gait, and ear canals almost closed by bone. Number 3. The Neanderthal who could not hear danger coming. When excavators entered Shanidar Cave in the Zagros Mountains of northern Iraq, they uncovered the skeleton of an older male Neanderthal. Known as Shanidar I, he had lived about 50,000 years ago and reached roughly 40 to 50 years of age, an advanced age for someone carrying the injuries visible across his body. Researchers noticed those injuries long before anyone examined the inside of his ears. A powerful blow had damaged the left side of the face, probably reducing vision in the left eye. The right arm was severely withered and ended above the elbow. Whether the lower arm had been lost through injury, disease, or removal after a failed fracture remains uncertain, but the limb had been largely unusable for years. Changes in the legs and feet show that he walked with an abnormal gait. Degenerative disease would have made movement more painful and restricted the back and joints further. For decades, Shanidar I was presented as one of the clearest examples of an injured Neanderthal surviving because other members of the group helped him. Then researchers looked inside two small openings in the sides of the skull. Bone had grown into both external ear canals. The growths are known as external auditory exostoses. Small ones may cause little or no difficulty. Shanidar ones were anything but small. On the left side, several bony masses reduced the canal to a narrow passage. On the right, growths extended from opposite walls until they formed a bridge across the opening, leaving only two small gaps. The obstruction belonged to the most severe grade. Normally, sound travels through the ear canal and vibrates the eardrum. When bone blocks that route, wax, water, and debris may collect behind the obstruction. Sound transmission weakens, even if the inner ear itself still functions. The result is conductive hearing loss. The right ear was probably functionally deaf. The left likely had substantial loss as well. That altered the entire survival problem. A damaged arm limits what a person can lift, carry, or make. Reduced vision in one eye may be partly compensated for by turning the head. A limp slows movement. Hearing loss affects what happens before the person realizes there is a problem. Shanidar I may have struggled to separate speech from background noise or identify the direction from which a warning came. During a hunt, he could miss instructions or fail to hear an animal moving nearby. While making stone tools, reduced auditory feedback may have made it harder to judge a sequence of blows. Alone in brush or uneven terrain, he might not hear a predator or another group approaching. Any one of those impairments might have been manageable. Together, they removed several of the usual ways a person compensates. Wild primates sometimes survive with one damaged eye or an injured hand. A human with one disability can reorganize life around the abilities that remain. Shanidar I had fewer and fewer abilities available to take over. The right arm offered little practical use. His gait reduced speed and stability. Vision was likely impaired on the left. Bone restricted hearing on both sides. Degenerative disease added pain and stiffness. How did a man with that combination reach later adulthood? In a hunting landscape filled with physical risk. The skeleton does not show that he was constantly carried or fed. He may have retained considerable independence, used tools effectively with his left hand, and performed work that did not require speed or two strong arms. A Neanderthal group was not made up of identical hunters performing the same task. Experience, memory, and technical skill could support roles that left no recognizable mark on bone. Still, independence does not mean isolation. People could approach Shanidar I from the side he saw more clearly. They might use gesture or touch when speech failed. The group could keep him close during movement or adjust tasks that required pursuit, balance, or two-handed strength. None of those actions had to resemble modern nursing. Together, they created a social environment in which his disabilities were less likely to become fatal. The hearing loss is the detail that changes the familiar story. Care was not necessarily limited to sharing food with an injured man. It may also have involved information, delivering warnings in a form he could detect, coordinating movement around someone who could not hear reliably, or communicating through the senses that still worked. Researchers cannot recover the motive. Shanidar I may have been loved, respected, protected through obligation, or valued for knowledge and skill. Several explanations may be true at once. The bones do not preserve kindness as a substance that can be tested. They preserve something more limited and more defensible. Repeated survival, despite overlapping losses of physical and sensory function. After death, Shanidar Cave protected his skeleton. During life, protection had to come from somewhere else. The bridge of bone inside the right ear measures only a few millimeters, yet it changes the identity of the man behind the fossil. He was not simply a one-armed Neanderthal. He was someone who moved with difficulty, saw imperfectly, and could not reliably hear danger approaching, yet remained within the working life of his group. The next skeleton presents an even more dramatic loss. The lower leg ended abruptly. The wound healed, and the individual lived for years afterward. The unresolved question is whether those years began with an operation or with a catastrophic accident. Number 2, the missing foot that refused to end a life. In 2020, archaeologists opened a small excavation trench in the floor of Liang Tebo, a limestone cave in Indonesian Borneo. Less than 1 meter below the surface, the outline of a grave began to appear. Stones had been positioned above the head and arms. A fragment of red ochre lay close to the jaw. The body had been placed on its back, with both knees drawn inward. Then the left leg simply stopped. The femur was still present. So were the upper portions of the tibia and fibula. But the lower third of both bones was missing, along with the ankle and the entire foot. This was not damage caused by excavation. The skeleton remained articulated, and the grave had enclosed the body soon after burial. Whatever removed the limb had taken place years before death. The surviving ends of the leg bones contained the timeline. They were not sharp, fresh breaks. The ends had narrowed and remodeled into irregular but healed surfaces. The left tibia and fibula were also smaller than the corresponding bones on the right, showing that the injury had occurred while the individual was still growing. The body had spent years reorganizing itself around the loss. The individual died at about 19 or 20 years old. Researchers estimated that the lower leg had disappeared 6 to 9 years earlier. A child had reached young adulthood without a foot, ankle, or lower leg. The missing bones recorded the injury. The surviving bones recorded the years that followed. The original research team interpreted the pattern as a deliberate surgical amputation. They argued that an accident violent enough to remove both bones would normally produce crushing, splintering, or other features that were absent from the remaining ends. They also found no clear skeletal evidence of the overwhelming infection expected after a severe, untreated, open injury. Under that interpretation, someone cut through living tissue and bone more than 31,000 years ago. The operator had to control bleeding, protect the wound, and keep the patient alive through the period of recovery. The cutting itself might have lasted minutes or hours. The greater danger came later. A severed artery could end the life within moments. Contamination might do it after several days. In a tropical environment, an open wound offered bacteria warmth, moisture, dead tissue, and direct access to bone. Even after the wound closed, the child still had to regain balance and learn to move while the remaining leg continued to grow. The terrain around Liang Tebo offered little help. The cave lies in steep limestone country, divided by rivers, ridges, and dense forest. A person without the lower leg could not move through that environment in the same way as everyone else. Food, water, and raw materials still needed to reach the patient. If the group traveled, someone may have carried the child, supported the body, or remained behind. Then trauma surgeons challenged the surgical interpretation. They proposed a different mechanism, a severe open fracture through the growth plates of the lower tibia and fibula. If a foot becomes trapped during a fall or sudden twist, the body may continue moving while the lower leg does not. The bones can break through the skin. The foot may be displaced. An infection can gradually destroy separated fragments. Damage to the growth plate would also help explain why. The injured lower leg remained smaller than the other one. The surgeons argued that thickening and small defects around the surviving bone ends might represent chronic osteomyelitis rather than uncomplicated healing after an operation. In their reconstruction, there was no prehistoric surgeon. A catastrophic accident destroyed the lower leg. An infection removed or damaged what remained. The original team responded that trauma and infection had already been considered. They maintained that the shape of the bones, the absence of expected fracture features, and the pattern of healing continued to support deliberate amputation. The argument has not been settled, but the disagreement does not erase the most secure evidence. In some ways, it brings that evidence into sharper focus. Whether someone intentionally removed the lower leg or an accident tore it apart, the child survived a massive open wound. Bleeding stopped. Infection was prevented, controlled, or survived. The foot was lost, and the individual continued living for another 6 to 9 years, while adapting to steep, forested terrain. Both explanations lead to the same practical problem. A growing child had to relearn movement after losing the lower leg. The headline claim is that Liang Tebo preserves the earliest known major surgical amputation. The more cautious, and perhaps more important story, begins after the leg was gone. A community did not need modern anatomical vocabulary to learn that pressure could slow bleeding. It did not need germ theory to observe that cleaning, dressing, or applying certain plant materials sometimes improved a wound. Useful knowledge can accumulate through repeated experience without ever being written down. Care did not have to be medical in a formal sense. It could mean carrying water, bringing food, modifying work, supporting movement, or slowing the pace for someone whose body now moved differently. None of those actions left direct archaeological traces. The healed ends of the tibia and fibula are their outcome. They mark the point where the leg disappears and where several more years of life begin. Number 1. The disease, hidden inside a family burial. In 1963, excavators working inside Grotta del Romito in southern Italy uncovered 2 people lying together beneath a rock shelter. One skeleton was visibly smaller than the other. The arms and legs were dramatically shortened, while the head and torso remained closer to ordinary proportions. The individual would have stood only about 110 centimeters tall. For decades, the skeleton was known as Romito II. Its proportions suggested a rare growth disorder called acromesomelic dysplasia. The condition shortens the middle and outer segments of the limbs, especially the forearms, lower legs, hands, and feet. But resemblance is not the same thing as a confirmed diagnosis. Several genetic conditions can produce similar skeletal proportions. Bone can show the final shape of the body, but it cannot reveal which altered biological instruction produced that shape. The grave contained other unanswered questions. Was Romito II male or female? Who was the larger individual lying so closely beside the smaller body? Were they relatives, companions, or 2 unrelated people placed together for reasons that could no longer be recovered? The burial preserved those questions for more than 12,000 years. The answer survived in one of the hardest parts of the skeleton. Researchers sampled the petrous portion of the temporal bone, the dense casing that surrounds the structures of the inner ear. Because it is exceptionally hard, petrous bone often protects ancient DNA better than other parts of the skeleton. Recovering fragments of DNA was only the beginning. The material had been exposed to excavation, handling, and storage, all of which could introduce modern contamination. Researchers examined patterns of molecular damage to distinguish genuinely ancient sequences from newer DNA left by people who had touched the remains. The first result corrected the identities. Both individuals were female. The genetic data also showed that they were first-degree relatives. DNA cannot write mother or daughter beside a skeleton, but the ages and the pattern of biological relationship made mother and daughter the most likely explanation. Then the researchers examined genes involved in skeletal growth. Romito II carried the same altered variant in both copies of a gene called NPR2. NPR2 helps regulate the signals that allow cartilage at the ends of growing bones to lengthen. When both copies of the gene are disrupted in this particular way, the result is acromesomelic dysplasia, Maroto type. The skeleton had suggested that diagnosis for years. The DNA confirmed it. Romito I, the larger woman beside her, carried only one altered copy of the variant. A single copy can produce shorter than average stature without, causing the severe limb shortening seen when 2 copies are inherited. The 2 women's bodies were therefore not unrelated medical curiosities. They preserved 2 expressions of the same genetic variant inside one family. The burial had become a genetic case history. DNA linked Romito II's skeletal proportions to a specific molecular cause. It corrected the earlier uncertainty over sex and identified the person beside her as a close biological relative. The gene, however, could not explain how Romito II experienced daily life. People with this disorder may have restricted movement at the elbows, shortened hands and feet, an altered gait, and difficulty covering long distances. Romito II lived among mobile hunter-gatherers. Movement was woven into survival. Groups followed animals, gathered seasonal resources, transported stone, and shifted between camps. Her body would have met those journeys differently from the bodies around her. She nevertheless survived into late adolescence. That survival should not be confused with helplessness. The disorder does not imply intellectual disability. It does not erase memory, judgment, skill, or social contribution. Romito too may have taken part in many activities and developed techniques suited to her body. Some demands, however, would have been difficult to avoid. A steep climb may have required a hand or a slower route. Limited reach could affect how tools were used. Carrying heavy loads over long distances may have been impractical. On longer journeys, the group may have adjusted its pace or helped her cross uneven ground. Those actions left no identifying mark on the skeleton. Researchers therefore described continued social support as a likely condition of survival, not as an emotion that could be read directly from DNA. The two women were buried in close physical contact, a position often described as an embrace. Kinship analysis now shows that the bodies belong to members of the same family. That finding does not tell us exactly what the older woman felt. It cannot establish who provided most of the daily support or whether care came from her alone. A genome can reveal inheritance. It cannot recover affection. What it can do is remove several layers of anonymity. Before the genetic analysis, Romito too was an individual with a suspected disorder, uncertain sex, and an unidentified burial companion. Afterward, she could be described more precisely. A young woman with a confirmed rare disease, carrying two altered copies of a genetic variant present in single form in her likely mother. Each line of evidence answers a different question. Skeletal proportions reveal the shape of the condition. DNA from the petrous bone identifies biological sex. Kinship analysis reconnects the two bodies. Clinical genetics explains why one family contained a mildly short adult and a daughter whose limbs were much more severely affected. Together, the evidence moves the case closer to biography than bone normally allows. It also places rare genetic disease deep within human history. The NPR2 variant passed through a family more than 12,000 years ago. One copy influenced the mother's stature. Two copies reshaped the daughter's arms and legs. The variant persisted because the people carrying it survived long enough for it to be inherited. Romito too reached the point at which the needs of childhood became the demands of adult life and adult movement. Whatever accommodation she received continued through repeated journeys, seasons, and changes in camp. This was not one dramatic rescue. At number 10, a healing fracture raised the question of who remained beside an injured child at Qafzeh. At Romito, DNA reduces the distance between the person who likely required assistance and at least one relative who may have shared her life from birth. The most defensible conclusion remains limited. The bones and genome demonstrate disability, survival, heredity, and family relationship. They strongly suggest support. They do not prove one specific emotion or reveal the private relationship between the two women. The final image does not require that kind of certainty. Two women were placed together beneath the rock shelter. One carried a single altered copy of NPR2. The other carried two. More than 12,000 years later, the dense bones surrounding their inner ears preserve the biological relationship that the grave had held in silence. The dead do not leave written accounts of every meal carried, every wound cleaned, or every journey slowed for another person. They leave healed fractures, altered joints, closed tooth sockets, narrowed ear canals, and genes protected inside hard bone. Each trace answers only part of the question. Together, the 10 cases show that human survival was never simply an individual contest in which the strongest body endured alone. Care did not begin as a hospital, a profession, or an institution. It appeared in practical decisions repeated over time, making food easier to eat, changing the work assigned to an injured person, protecting an open wound, carrying someone who could not walk, and returning the following day to do the same thing again. The motives remain beyond the reach of archaeology. The physical consequences do not. Across all 10 skeletons, the evidence is most convincing when the conclusion remains no larger than the mark left in the bone. Which of these cases changed the way you think about ancient human care? Share it in the comments, and subscribe for more investigations built from the physical evidence the past left behind.